So the first question I have for you would be related to the most recent REDUCE-IT analyses we've seen, which is actually an analysis of REDUCE-IT REVASC. Now, could you just sort of take me through the purpose of this analysis and what it adds to our understanding of total events and the reduction of that caused by REDUCE-IT or caused by icosapent ethyl?
Absolutely. So coronary revascularization was part of the primary composite endpoint. And as we reported in the New England Journal of Medicine, it was significantly reduced. So that was actually in the New England Journal of Medicine paper as part of a 5-point major adverse cardiovascular event composite. And that was the time to first event. What we have reported now, or actually I should say what one of my interventional cardiology fellows, Ben Peterson, had reported as a late breaker at Sky, was a deeper dive into the coronary revascularization endpoint, showing overall a reduction of 34% in relative terms, 4% or so in absolute terms in coronary revascularization over the duration of the trial. So that was the overall finding. In addition to that, which I think was pretty important, what he had reported there was a significant reduction in elective, emergent, and urgent revascularization as discrete categories. And furthermore, showed data that as far as coronary revascularization goes, the time to percutaneous coronary intervention as an endpoint was significantly reduced. That was 32% lower. But also that the time to coronary artery bypass grafting was significantly reduced to 39% relative risk reduction there. So that in particular struck us as very important and novel, that even in a blinded trial with independent adjudication of endpoints, the need for coronary artery bypass graft surgery was significantly reduced, pointing to the profound reductions in atherosclerotic burden that must be occurring with use of the drug. So that was at Sky, or the Society of Cardiovascular Angiography, as a late-breaking clinical trial. Now, what I presented as an encore late breaker at the American Society of Preventive Cardiology was a recap of that, but then some additional data taking things even further in terms of evaluating the timing of benefit. And what we demonstrated was that there's a very early benefit we're seeing here in coronary revascularization, again in this blinded trial with independent adjudication of endpoints done by Mike Gibson's group, as a matter of fact. And what we're seeing is a significant reduction in coronary revascularization by 11 months. So that's probably much earlier than people were thinking icosapent ethyl is working in a stable cardiovascular population. And in fact, the hazard ratios, even before the 11 months, were close to statistically significant, but achieved sustained statistical significance by 11 months. In fact, the benefit seemed even earlier, occurring relatively soon after randomization. So unlike what I think most people were assuming was the case with icosapent ethyl, where it just takes years to work, in fact, the benefits do seem to be kicking in pretty early. And this is in line with what was noted in the interim analysis, the pre-specified interim analysis from Evaporate, which has now been published in Cardiovascular Research, where that showed in that coronary CT imaging study that there was a significant effect on plaque progression with icosapent ethyl versus placebo by 9 months. So that's very similar to what we're seeing here. By 11 months, a significant reduction. And as I said, there's even evidence before that 11-month time point of the hazard ratio for coronary revascularization being well below 1. That is, suggesting that there's very early benefit. I'll point out to your viewers that in REDUCE-IT, these were stable outpatients that we enrolled, and we excluded by protocol patients with planned coronary revascularizations. So the patients who would have been at highest risk of repeat revascularizations or de novo revascularizations were excluded by protocol from the study. So the effect sizes we're seeing here, both in relative and absolute terms, are large and are early, but are probably still an underestimate of the actual potential benefit if we were to use the drug, say in patients who had just undergone coronary revascularization or who were at very high risk of it. So I think that these results, especially when viewed in a historical context, are really quite important, because if you think back to trials in the past, like historic trials, the 4S trial of statins, for example. You know, there was a significant reduction in revascularization as well. But now what we're seeing is a risk reduction that really, in terms of magnitude of effect, is quite in that ballpark of 4S, but in a statin-treated population. So this is an incremental reduction beyond, say, statin versus placebo, just to put that in the proper context. And indeed, the reduction in revascularization we're seeing here exceeds what other therapies beyond those initial statin trials had shown. So I think that the effects are really quite clinically relevant and could have a major impact on the way we treat patients who are at risk for coronary revascularization, which is a lot of patients.
All right, thank you for that. Now, when we're talking about the clinical relevance of these results, I know in the past when we've discussed Reduce It, you suggested that maybe total events is the way that most patients like to look at the impacts of these studies. In this world of people wanting effects immediately and to see results of the medications that they take, what kind of added tool is this that clinicians can tell their patients they'll see benefit that in comparison to other drugs is pretty immediate given the 11 months that you guys found in this study?
Sure. Well, you mentioned total events. I guess I should complete the picture. I was so far just referring to first events. If we look at total revascularization events in this data set and reduce it, we see a 36% reduction in total revascularization. And even when we put it in a multivariable model, we see that the only thing that emerges as a predictor of lower risk of revascularization is the icosapent ethyl, again, a 36% relative risk reduction there, whereas predictors of revascularization are the usual culprits, things like a history of prior PCI, being male versus female, having diabetes versus not having diabetes, having elevated triglycerides or elevated CRP were all predictors, independent predictors of revascularization. But those were predictors of having it. The only predictor in our multivariable model of not having it was treatment with icosapent ethyl, randomization icosapent ethyl. So, you know, that's the overall sort of impact clinically. Now, obviously, there are cost effectiveness implications of this. We didn't examine that in this particular analysis, but Dr. Bill Weintraub has already presented Reduce It cost effectiveness analyses at the last American Heart Association as a late breaker, showing that the drug is highly cost effective in most of the scenario analyses. In fact, a dominant strategy, meaning not only cost effective, but actually cost saving. So I think revascularization is an important part of that story because obviously, let's talk about the US healthcare system, revascularization is a very expensive event, whether it's PCI and in particular when it is CABG. So, you know, those are implications at a societal level. Now, from an individual patient level, as you asked, certainly what we've seen in the overall trial is that the longer patients are on therapy, the more the curves separate. That is, the greater the degree of benefit on first ischemic events, and in particular on recurrent or repeat events. So that totality of the atherothrombotic burden is very significantly reduced, about a 32% reduction there, with significant reductions in first, second, third, and even fourth or more events. We published that in the Journal of the American College of Cardiology. So I think that these data really help complete that picture with the added insight, and perhaps this is a particularly important point for patients, that the benefits do also kick in early. It's not just a matter of if you're on it for a long time, you get benefits. That's true, of course, as with statins or other effective therapies. But here, there's a benefit that's kicking in pretty early. And this, as I also alluded to, dovetails quite nicely with the evaporate interim analyses results. Now, of course, we have to see what the final results of evaporate are, but even at the interim point, a variety of different measures of plaque volume were significantly favorably influenced by icosapent ethyl versus placebo. So now we've got mechanistic data showing benefits occurring on the order of months with icosapent ethyl versus placebo from evaporate. We have large cardiovascular outcome trial data from Reduce It showing a relatively early benefit on this endpoint of revascularization, again, within months of randomization. So I think it really paints a cohesive picture of how this drug is working, not only in terms of preventing later cardiovascular events, but even earlier ones. again, from a patient's perspective, as you asked, that might be useful information for them to know.